¿Cómo amanecieron? Thank you for coming. Really appreciate it. What we want is to tell people how amazing the day of a geriatrician could be. It's very interesting, is all about interacting with people, teaching our learners, and enjoy what we're doing every day. I mean, that's pretty much what it is. It's very basic. There's not too much science about why we enjoy what we do. All I can tell you is that if you look at geriatrics as a subspecialty, we are the subspecialty, one of the most highest career satisfactions. Okay. So how my day starts is, in addition to my role at FAU, I'm the Associate Medical Director for Hospital and Medicine at the Reyes Medical Center. Okay. So my day starts around 5:30 in the morning, between 5:30 and 5, depending. And then I receive a census, is a list of every single patient that is admitted to the hospital under the care of the internal medicine service or FAU. Okay, so this is the list of today. Okay. And then what I usually do is I create an Excel file with the list, and then I assign these patients to everybody. Okay, and this is how the day starts. You see, and then I get phone calls from everybody. Hi Daniel, how are you doing? That just came in is an event that happened overnight in one of the patients that we covered, and sometimes there are breaks in communication, and those are opportunities that we use to learn and to teach others so we can improve patient care. Okay, so once I get the distribution of all these patients, I send the list to every single provider. Okay, then I go to the teaching list. Okay, so the teaching list is all the patients that are in the teaching services that we have here as well, right? Okay, I look at random things like, if the HMPs have been dictated. So the HMP is the first part, well, you know that already because you're a medical student, so your history and physical. And I looked at documentation is appropriate, and then I look at my own patients. Okay, so I depending on the day. Then I actually plan my day depending on how many patients I have. I check up with the residents early in the morning to see if there are any issues that happened last night, anything that I should address immediately, any problems with families, and things like that. Once I had done all that, okay, then I usually grab my list. And then my list usually, it depends depending on the day, but my list is usually very short. I just print mine, so it's usually a very short list. And then what I do is I review labs, and then I check at again events that happen overnight with my own patients. Okay.
So even though you have a short list, there's a big list of patients that the residents receive.
So and also again as I oversee also the private part. So the non-teaching patients, okay. Then also I have to distribute those patients, but I do that early in the morning. So by 6 o'clock in the morning, everybody receives a message with the patients that they have to see that day. So I usually do that between 5 and 6 o'clock in the morning every day. Okay, so by 6 all those things are distributed and done. Things that obviously you won't see on tape is I get ready. I have 4 kids, so I took 2 of them to the bus stop almost every day, and then I come to work.
What time do you usually wake up?
Around 4:30 in the morning. So
4:30.
Yeah.
Wow.
So, but I mean that's only because I'm an early riser, and I really enjoyed my afternoons. So usually, with the exception of today is going to be a particularly long day. But with the exception of today, usually by 4:30, I'm done with my day and I can drive home. So I have a commute, so I drive for an hour. But then during that time, I usually listen to podcasts or I return phone calls to patients' families sometimes, or to own patients. Yeah.
What about yourself? yourself?
My name is Bernardo. I'm a second-year resident here at FAU. Internal medicine, planning on going to ID, hopefully.
You're working with Dr. Reyes today?
Yes, Dr. Reyes is my APD, and he's my mentor through the program.
Okay.
So, I'm working with him on geriatrics this week, so
Great.
thank you for having me on camera.
Thank you. Thank
I did a chest x-ray early morning, showed some worsening CHF. So I was going to give him, I don't know how you feel, I know some of the attendings feel iffy about this. I was going to give him a 25% albumin and give him a dose of Reyes.
Okay,
His cardiac function went up too.
I'm okay with that approach, but there is actually a study in New England Journal of Medicine that just came out like 2 weeks ago, testing the effectiveness of albumin on
It's just not effective.
It's
right?
not effective at all. But that being said, it's not in this patient population.
Yeah.
And these guys failed. We just came out of surgery, so let's see if that helps a little bit.
His cardiac function got worse, so.
So do you think it's cardiorenal? Maybe?
Yeah, that's what I was thinking.
Okay, if it's cardiorenal, maybe we should try to get an echo stat straight away.
So there's only one order. She didn't order one this morning.
Sometimes when some of the residents actually see the patients, if the staff has any questions, they usually go and call me. Most of the times I encourage everybody to call the residents first because they are, although they work under my supervision, they are physicians and they learn from those experiences too. And that's what I was actually telling them. So although they want to pass the information to me and I could actually fix the problem myself, what I usually do is I use that as a learning opportunity for people to learn about different aspects of healthcare.
Jamie, he looks like he's volleyball.
So if you
Check out him a little bit later.
okay, I can stop by right now because
Okay.
I'm in my way there.
You don't go see him. I'll come see him with you.
Can you tell us what you like about geriatrics?
I think that the patient population, it's a big deal. They're not, once they get to this age, they're on so many medications, as they're going through the years that some of these meds shouldn't be continued. So, you get into your 80s, 90s, you have side effects that affect you even more. So, it's good for us to help them out and take these medications off that shouldn't really be there. Like an example that Dr. Reyes brings up is, why should a patient who is like 95, 96 be on a statin if they're only using that to cut down their cardiovascular risk? They're at that age, why continue those medications? A statin can cause myopathy, and if they're suffering from the myopathy, what's the quality of life for these patients? So, it's good to like help these people out and try to improve their quality of life, get them to the right nursing facilities or proper care for them. So I guess that's what be
And
my
most of
answer.
them go to rehab, right?
Yeah, rehab, nursing facilities, assisted living facilities, those type of places. That's where they usually go.
Okay, thank you.
Gotcha.
So one of the things I enjoy a lot, and one thing I'm passionate about is it's actually healthcare finances. So think about this. We are by far the country that spends the most in healthcare, by far. And we don't have the best outcomes. So there has to be an issue, right? Our infrastructure should allow us to provide the best care possible at the most affordable way. And we're not doing that. So I had the pleasure actually to lecture
Financing and sites of care.
Yeah.
Okay.
And so I gave a lecture to actually the medical students just now. And it is a great experience because one of the things I'm concerned, especially, there are two things that concern me a lot. The first one is how fast we're spending money. So every year we're spending more and more and more. And the fascinating thing is that a small portion of the population, maybe 5% of the population, spend up to 50% of the money. And guess what? You know who is in that 5%? Older adults. So as a geriatrician, imagine having the opportunity to change our healthcare system in a way that we can save those resources and still provide amazing care to our older patients. Okay.
What were the second years or third years?
It was the second years.
The second
Yeah.
years. Okay.
Yeah,
That's
but
nice.
it was I really enjoyed it. So what I was saying is that after I spent all these years traveling and doing fellowships and residencies. What really helped my career a lot was actually becoming a geriatrician here at FAU. I mean, my career has advanced so much since I joined this institution. I mean, and my day, as you can see, is full of activity, and it's never the same. There is always something exciting, that happens on my day, and I love that. And at the same time, I have the opportunity to interact with students, residents, nurses, patients, and I still have time to spend time with my family, and at the same time, work in projects that I'm passionate about, like writing book chapters with fellow FAU faculty, even with I actually have finished projects with medical students and with my residents. And also going to different conferences to present not only the work that we do at FAU, but also as a lecturer, as a speaker, as an invited speaker. So, I mean, this job has given me the opportunity to do all that and still provide a living for my family.
What is your favorite part of working with older adults?
They are the best patients on earth. They are the most grateful people on earth. They appreciate so much what you do for them, because imagine they're in their frailest state. When they're sick here in the hospital, imagine they're scared. Yeah. Imagine being somebody that is 80, 90. Every time you make it to the hospital, you never know if you're going to come out alive of it.
Right.
And you being the person that provides that care, that comfort, and help them and treat them with respect. That's what they care about. They want to be treated with respect. They're human beings too. They have amazing histories. So that's the other one.
Yeah.
You learn about them, and some of them are World War II veterans, for example. They were in D-Day, okay, and or they invented things. I mean, I have patients that invented stuff that we use every day. Wow. and having those experiences, knowing these people that were the best of the best, is amazing. It's what makes these specialty the best. You see how complex these patients are. You have seen it around them with Dr. Sony. But you can treat CHF, you can repair a hip, but what happens after you discharge the person? And then this is what we call elements of enhanced discharge planning. Okay, there are social determinants of health that are included in this program. It's called the STAR program because it goes for transitions of care, safe transitions of care for at-risk older adults. Okay, that's the STAR. That's what the STAR. And Dr. Joe actually came up with this. This has been described in the literature many times. These are factors that can affect your risk of coming to the hospital within 30 days after you get discharged. Okay? Yeah. And there are function, hearing, and vision. You have seen how impaired these people could be. So imagine so imagine these two patients that had hip fractures. Mm-hmm. Imagine how difficult it's going to be for them to go back home and function at the same level that they had. Right. And also, if they don't hear, they don't see well. If they don't hear well, they can become agitated because they don't understand what's going on in their rooms. If they don't see exactly the same, if they don't see, they can fall. Medications, if I start or stop medications in the hospital, who's going to follow on those changes on the medications? Same as cognition. If I tell somebody you need to take this medication 3 times a day and it's a brand new medication, if they have dementia, how they're going to do that? So I have to evaluate cognition.
Do we call the PCPs?
Yeah, but the PCP also is going to give a prescription. Who's going to give the medication to the patient, right? If the patient doesn't remember. Nutrition. Okay, we have people that come with exacerbations of heart failure, and most of the times it's because they don't follow a diet. And they don't follow a diet sometimes because they don't have access to food. Their food is actually, they take, frozen dinners. That's the only thing that they can cook. So they don't have access to healthy food. And social support. If I have somebody that needs somebody to cook for them, that needs somebody to drive for them, and they don't have, what happens with all this? None of this is going to happen unless there are proper social support. And depending on that, then we can create a transitions of care plan that makes sense when you look at all these other 5 factors. So that's pretty much the 6 components of the STAR program. Let's talk about
sicker one.
Yeah.
So he's a 90-year-old male, history of hypertension, CAD, status was cabbage, AFib on warfarin, had the left femoral neck fracture, status was hemiarthroplasty yesterday. Overnight, he had the hypotensive event, lowest down to 60s over 30s. And so Shaheen was called, and he gave 500 cc bolus, to which the patient responded. He was like back up to the 90s over 60s, and then he got a repeat CBC and BMP, which showed the hemoglobin at like 9.6 from 10.2 earlier prior to the procedure. So it's 9.6, and then he got the BMP showed the creatinine had bumped up to 2.7 from 2.5, and then he got a chest X-ray which showed that pretty congestive changes, especially compared to the initial chest X-ray that came in. Definitely looked more fluid overloaded. So this morning, I mean, he's mentating at his baseline compared to how he was prior to the procedure. He's still he was eating when I saw him right now, and his wife is there at the bedside. The wife said he had like a delirious episode last night where he became kind of confused and didn't know where he was and wasn't letting people touch him, and that she had to come in at night to help out with the situation. That's what she was saying. But he's back at baseline now. Physical exam wise, so the vitals, like I said, 65 over 33. The most recent pressure is 82 over 45. And there was one reading of oxygen saturation 74 to 78. Repeat urine lights, the FeNA came out to 0.1.
0. Even with the diuretic.
Exactly.
So it's very preventable.
Yeah. And with that congestive changes, that's kind of what my thinking was, because the hemoglobin stayed stable, but he was still hypotensive, and the creatinine got worse. So I don't know if the creatinine just kind of pushed the hypotensive episode kind of worsened the kidney function, and then the congestive changes. So that was kind of my thinking.
For the albumin and the but you're assuming that there is a this is purely cardiorenal.
Yeah.
Okay, and we don't have an echo yet.
No, that's ordered. I can try to bring some of that fluid back in, and then push out with the Lasix. The other thing is, when I went to go see him, like the drain from the hip site, there is blood coming out. So there's a repeat at the CBC that was just drawn with the BMP.
Okay.
And just to make sure the hemoglobin isn't dropping quickly, and that's what's adding to the low blood pressures.
Let's see if we can recheck an INR, because the guy was taking.
I pulled it in. All right. I didn't start the. So I was going to start the warfarin, but once I saw the blood, I told the nurse to push it back, and then I just canceled it.
So would you consider doing maybe sub-Q heparin in the meantime?
I mean, we can.
I mean,
I'm just nervous about if there's a bleed. If the hemoglobin's stable that's being drawn right now, then I'll start on sub-Q heparin.
Okay. Sounds like we might definitely need to get that echo read sooner than later. Given albumin doesn't really even elevate the albumin level, the oncotic pressure. So is that relevant to this patient population? No, because it's not the same. But I would say that using albumin has to there is no evidence base. Arm? Okay, that means your heart is working, right?
Yeah.
Okay, and you're not. The issue is when you're here.
Yeah.
So that means that you're not only wet, you don't have perfusion.
Yeah.
And that's my concern.
Yeah.
That we're reaching this. You don't have a filter. You know this. Whatever we know each other, and we know what each other know. That's the issue.
But it's good because you guys are exchanging knowledge, right?
Yeah. Usually it's more this way.
Oh.
There's a lot of people actually just teach me more than what I teach them. So, okay, so let's go to the next one.
Okay. First was a little low at 1.8, which I depleted. So in terms of plan for the C. diff, we have him on the PO bank. We DC'd the Flagyl and the Cipro yesterday. His white count is coming down as well, by the way. His white count is 27 from 33. So everything's slowly trending down. His anemia is stable. There was some concern whether he was bleeding, but his hemoglobin has stabilized, and his AKI has resolved. And then for his diabetes, he's on a sliding scale.
He had urinary retention when he came, and he has a little bit of AKI.
Yeah.
So I put
he has a Foley.
I put a Foley in, so we might need to consider getting the Foley out.
Okay. I mean, yeah, I might as well do a voting trial today then wait.
Let's try to do it then, yeah. I think it's great. And then try to mobilize him a little bit.
Okay.
Get him out of bed, optimize medications, get the Foley out. Mentation, he's at baseline, right?
Yeah.
And has he told you anything that matters to him at all? Or he just wants to get out of
He
here?
wants to leave, yeah.
Okay.
Pressure. So she was at home watching TV, and then all of a sudden for 30 minutes she felt her heart was pounding, and then she had associated chest pressure with no radiation. She had no numbness or tingling in the hands. She said she's had the chest pressure before, and then she saw her PCP and she put her on a PPI, thinking that it was all GERD related. And the palpitation she's never had before. This is the first time. So she called EMS, and they came, picked her up, and it looks like the telestrip shows AFib with RVR. She was in the 150s. And then they gave her some medication. We don't know what it is. She doesn't know. And by the time she got to the ED, she was a normal sinus. So in the ED, they placed her on a heparin drip. And she remained in normal sinus throughout today, and since she's been in the ED. The one issue is her trope went up to like from 9 to 22, and then came back down to 17. Repeat EKG didn't show any changes from the initial admission EKG either. In terms of physical exam for her exam was pretty benign for me. She was still in regular rate rhythm when I listened to her. She was in no acute distress, no abdominal tenderness, no lower extremity edema. I can go through her Geri assessment. So she lives at home by herself, completely does all of her ADLs.
There is a paper, a position paper they came up with in 2018, and I have it in my computer, I will share it with you, that shows that the way that you approach anticoagulation and atrial fibrillation, obviously the duration of the episode has to be a lot with it. But also there has to be also risk factors. So it's just your chest vas, pros, So she had a chest vas of 3, but then you have to see like, okay, for how long was that run? How many runs?
Yeah.
And so far you have no proof that she had atrial fibrillation.
Exactly. Yeah, I mean, we have that one tele strip from the EMS.
But then it was an isolated episode.
Yeah, exactly.
So what you should do, what you're doing, so you put him up, most likely you put a loop recorder, you don't put her on anticoagulation, and you wait to see what happens.
Yeah, which is exactly what I explained to her.
Yeah. Because I always tell him, are you 100% sure? I'm 100% sure, Dr. Reyes. You're 100% sure? I'm 100% sure, Dr. Reyes. Okay. Go for it. And then a year after, he still they still learn from that. Huh?
Never forget.
Never forget, right?
So you have a new resident every week?
I have a new resident usually every week. He's the second. The other reason why he's the second time that he's here, actually.
Oh.
So yeah, for him this is not new.
Hi guys, so now we're transferring to the clinic part. I'm just waiting for Dr. Reyes. We're driving from the hospital to the clinic, outpatient. And yeah, we're gonna learn some more and follow him through the rest of his day.
So she had only no polyps. Biopsy was okay. Then
yeah, so she's had this right shoulder pain that's been intermittent. It really sounds like a spasm. She's had a knot there, and she's responded well to Flexeril before, and she's asking for to get today.
that's okay. I mean, the only thing is also she has to have like some physical therapy, maybe, and occupational therapy.
Yeah, absolutely.
He has a history of dilated cardiomyopathy, unknown etiology. The only kind of running theory is from COVID. Initial EF was 10 to 15%, initially on a light vest. He also has a history of polycythemia, again of unknown etiology, although there was some testosterone use a few years ago. He is presenting today for follow-up.
And when you said that the unknown origin, what kind of workup we have done so far?
JAK2 is negative.
How about anything else that you need to do actually?
EPO level.
Yeah, is the EPO level also?
I didn't see reported.
That's, I mean, if your EPO level is high or unexpectedly normal, I mean, that's one thing that maybe we could look at. Does he have history of smoking?
Former smoker, about 20 years ago.
This is a more relaxed environment. I mean, cell phones, as you can see, are not ringing. I don't have people, asking me stuff all the time. I don't have people actually stopping me, actually asking me questions. So it's a very, for me at least, is a place where I interact with people in a way that is very difficult to do in the clinic. So as you can see, I can sit down and pretty much on the floor and talk to somebody. And so I enjoy the interactions I have with the patients in the hospital, but I enjoy more the interactions that I have here because these are patients that are established with us. So they are familiar, with our care. And they come to see you because they trust you. So that this is a different relationship. And when you look at geriatric patients, they need so much having that connection, having that person that they can trust. That sometimes they don't do anything. I mean, I haven't done anything for the last patient who was already. I mean, all I did was saying what Dr. Godinez is doing is fine with me. And for them, that's enough. All they want to hear from you is that things are okay, or what we're doing right now is the right thing to do. That's all they want to hear.
Okay. Any other reflections from the day?
I have the best, again, I still believe being a geriatrician is the best thing on earth. As you can see, it's a busy day, but you can choose how your day is going to be, depending on what you like. I mean, there are people that are staying in an office like this one every day. There are people that stay in the hospital every day. There are people that are teaching every day. I make the choice of doing all, and because I like it all and I enjoy being with people like you.
Awesome. What is the hardest part of geriatrics?
The hardest part of being a geriatrician is, I don't know, there's not just, you have to be patient. I mean, the geriatric patients, they live at their own pace. They are not going to go slower or faster for you. Okay? And they feel entitled, and rightfully so, that people should accommodate their needs. Rightfully so. They live a plentiful life, they raise children, and they work really hard to make it where they are. So I think that the most challenging part usually is within your busy schedule, within how fast things occur nowadays, that you need to slow down your day to explain things to people, to do things at a pace that is different than what we do every day in our lives.
What is the training like for a geriatrician?
Well, I mean, the start of the training is after you complete an internal medicine residency or family medicine for 3 years after medical school. Then you can do a 1 or 2 year fellowship. And it's heavily dependent on how academic you want to be. 2-year fellowships are usually for people that are more interested in an academic career.
What kind of research is being done now in geriatric medicine?
Well, actually, aging research is a very interesting area of medical research nowadays. When the first geriatricians in this country, the pioneers like Dr. Joe, were being trained, most of the knowledge was based on experiences of providers, and thanks to people like Dr. Auslander, who actually spent his life generating medical evidence for people like me to actually use it. Big things now are dementia. I mean, I think if I have to pick the biggest ticket item in medical research is going to be dementia, and also frailty. I mean, so as you age, the concept of frailty is so complex and is understood by what it means clinically and phenotypically has not been studied enough in terms of the reasons why it happens and how we can prevent complications associated with frailty, such as sarcopenia, for example. There's going to be more need for geriatricians and hopefully, it sounds bad, but market dictates what happens to every industry, and I know it sounds horrible and to say something like this in healthcare, but the need for geriatricians is so dire right now that more fellowships are being opened. There are more private practices and big corporations trying to invest in geriatric infrastructure and actually hiring geriatricians, giving financial incentives to students and to residents to become geriatricians, student loan repayment, or complete waive actually of to their moments just to become a geriatrician and practice as a geriatrician for a period of time. And again, hopefully, what I see in the future is that geriatricians not only become the frontline providers, they become the people that educate other providers. It's training the existing workforce to do the work that needs to be done. And if you are a board certified geriatrician, pretty much you can work in any place in this country. There's such a need. Believe me, it's amazing.
I believe you. I don't know many
We're trying to hire
geriatricians.
one right now at FAU. Yes.
Nice. Thank you so much for
Thank you, guys.
letting us do this.
No, thank you for coming up with this.